Thanks for joining us. I'm your host, Raquel Faria. I am a doctor in internal medicine at the Centro Hospitalar Universitário do Porto. Today, I'm joined by Professors Andrea, Doria and Thomas Doerner from the Lupus Academy Steering Committee, who will be providing expert insights from the key research and clinical data presented at the 13th European Lupus Meeting 2022. This year's meeting saw participants so eager to be together in person. The opening ceremony included wonderful insights and absolutely beautiful singing from a lupus patient. And the welcome dinner and networking breaks were almost like it was before COVID. Andrea and Thomas, welcome and thank you so much for joining us today.
Hello to everybody.
Yes, hello. Also, it's a pleasure to be here, and I would like to welcome you all, and thanks for the very kind introduction and invitation.
So during the meeting, we saw presentations of data from clinical trials, both from belimumab, deucravacitinib, I think I got it right, voclosporin, and several other investigational treatments for SLE. Thomas, what do you think were the research highlights of this meeting for you, and what insights can you offer from the potential use of these novel treatments in clinical practice?
Yeah, first of all, I completely agree with you. It was exciting to meet the colleagues again after the pandemic, let's say, break in between. And the scientific networking really took off again. And I think for me, the most impressive data came from the insights from using deucravacitinib in lupus, the PASLE trial, which is a kind of novel approach for the blockade of JAK-STAT inhibition, because it's a particular TYK2 inhibitor, which is somehow different from the molecular structure and target as the other conventional JAK1, JAK1/3, JAK1/2 inhibitors. And for me, the amazing thing was that really a study evaluating different dosages of 3, 6, and higher milligram twice a day compared to placebo turned out very remarkably with a lower dose, substantially differentiating from placebo. That's one thing. In phase 2, we all know phase 2 in lupus, take it with caution. But what was really very impressive for me in this 32-week trial, the safety was really remarkable in a lupus population where we expect a lot of, let's say, increases of infections, herpes zoster reactivation, MACE, VTEs. This was really remarkable. And if this can be confirmed in phase 3 trials, which I assume is ongoing, then this could be really a new approach with an oral formulation in lupus. In particular, I admire the safety side, what we have seen in Stockholm at the EULA meeting.
Andrea, I'm sure you also think something like that, but do you want to add any particular aspect of it?
No, I agree with Thomas that one of the most interesting result is that reported in the deucravacitinib study, because it is a new drug in lupus, and the results, especially as Thomas mentioned, with the 3 milligram BCNDA, were really very convincing. If I can add another study that we are expecting, and that in my opinion, the result is are very important for us, is the long-term extension study of the voclosporin, because we knew the positive effect of voclosporin in the phase 3 trials, but we were a little bit worried about the tolerability of this drug, just in order because we know that the calcineurin inhibitors can induce a decrease in glomerular filtration rate and increase in the blood pressures. And instead, the result of the extension study of 2 years after the end of the phase 3 study are the results are very reassuring, because the glomerular filtration rate and the blood pressure of patients enrolled in this study were very stable over time. Of course, in addition, they also confirmed the efficacy of the drugs also in the long term. So I think that it is in our clinical practice, I think that this is another important result which were presented during the Congress.
Did it put you more prone to think of using voclosporin in the near future?
Yes, because as mentioned before, we were a little bit worried about the potential side effect. And now I am much more convinced that the drugs is also well tolerated.
For both of you, you please choose who wants to answer first. Were you surprised with the sub-analysis of the European cohort of the belimumab trials in the lupus nephritis trials?
If I can start, I was very much, let's say, surprised to see that the effect size in the lupus, in the BLISS-LN long-term or extension trial was not as the general population that has been enrolled in the study. But if you look carefully into the details, I think effect size on the one hand is an important issue, but it could also be demonstrated that over time, the glucocorticoid reduction was very substantial, significant in this population. And maybe this has something to do that among European centers, there is more strictness, that's my impression, in terms of the daily glucocorticoid usage, which on the other hand is another factor of effect size, but also the ability and the significance of reducing daily glucocorticoids. That is a characteristic of the European centers. So I take it not only that the effect size was lower, it also needs to be taken into account that the daily prednisolone dosage in these centers was below 7.5 and below 5 milligram, really on a very substantial number of patients.
For those who are hearing us, you can consult the steering committee resume in our site, so you can go through with us with a discussion of the results. Andrea, do you think that this kind of results of not so much effect on the BLISS-LN, on the European cohort, could be related of these patients were more prone to be chosen to cyclophosphamide than MMF? And with this in hand, would you still consider belimumab in a head-on position in lupus nephritis in patients in the European cohorts, both with cyclophosphamide or MMF?
Yes, Raquel. First of all, we have to remind that this post-hoc analysis was focused on a small number of patients. It was less than less than one on 4 compared with the original paper. There are 89 over 400 and more. And so it is clear that this post-hoc was not powered to demonstrate a difference. Yes. But it is true, I agree with you, that maybe the drug is more effective when used in addition to the MMF. it has also to be mentioned that in the trials, the cyclophosphamide was used according to the Euro Lupus project and not with the NIH scheme that are the scheme that, for example, I used more than in my clinical practice. But it is also true that I am trying to use as less cyclophosphamide as I can, and I reserved cyclophosphamide only in patients with a very severe, with a renal insufficiency, with a chronic lesion in the biopsy, and the MMF is of course much in my clinical practice is much more used than cyclophosphamide. And what we can say that looking at this data, it seems that it could be that MMF has a synergic effect with belimumab. But really the effect either of belimumab and the MMF are on the immune system, specifically on the lymphocyte. B cell for belimumab, B and T cells for MMF, and so I think that it could be that it is a synergic effect.
I think that the worry would be if people look blindly to these results, would think, oh, belimumab is not a good drug to use in European courts in lupus nephritis, but probably belimumab should be seen as another kind of drug, like a long-term flare preventions, long-term damage accrual prevention, and this still to be discussed. Do you want to add anything on this specific point? Thomas?
Thanks for raising this point. And I think belimumab, I call it all the time a marathon runner. If it's very persistent, over time it shows very potent, let's say, control of disease activity. One cannot compare belimumab, the kinetics of the response to belimumab with a lot of other drugs, including MMF, cyclophosphamide, and not with prednisolone, high-dose prednisolone dosages. But if it works, we see really very good, stable control without flaring patients in a substantial portions of patients. So there are all the time exceptions, but if patients are tolerating, it's really very well tolerated, belimumab, and they show some improvements that's over time really stable and it's getting year by year better. And I think there is still some promise in the future that we might see some of the patients, hopefully, that lupus is completely under control and we do not need any other immunosuppressive therapy. That is a possibility. We have seen, all of us, a few patients who really, with the exception of remaining ANA, anti-nuclear antibody production, had completely resolvement or remission of the disease.
Andrea, do you want to add anything on this particular point?
I agree completely with Thomas. There are 5 phase 3 randomized controlled trials, long-term extension study, real-world data, which tell us that belimumab, in addition to the standard of care, is able to reduce the disease activity, to save glucocorticoids, to reduce the risk of flares, especially severe flares, and also is able to dampen the damage progression. And so there are all the things that we are into in our clinical practice, our targets.
And this really needs to be, it's like changing your mindset when you think of treatment in lupus. And going with this, I found a little bit surprising, I don't know what you think about, of the doses of belimumab that were used and IV versus subcutaneous had different results when it comes to preventing renal flares. There were huge numbers of patients. So do you think this is really what's happening? Was this due to something that we are not seeing, the different outcomes in the prevention of renal flares from the IV doses to the subcutaneous doses? Thomas?
That's a puzzling observation, and I would love to give you a more correct answer. I was somehow surprised because I thought that in particular the subcut formulation is designed to, let's say, almost being equal in terms of the efficacy to with the IV dosage. It might have some pharmacokinetic differences what have not been so far let's say delineated, or it's simply by chance a difference that is maybe cannot be but the data are the data. I cannot give you a good answer.
Do you have any insight, Andrea?
Not specifically. Again, we can also underline that the number of patients treated with the subacute was much lower than treated with the IV, and so maybe the difference is in the population, in the number of patients treated. Again, but
yes, but
for example, in the subacute, also in the subacute, in the 52. Weeks phase 3 randomized controlled trial, the result was that the drug is able to reduce the risk of severe flares.
Yes.
Specifically the renal, but the severe flares.
Thomas, you wanted to add something.
But maybe there is another aspect of this pooled analysis, that is the co-medication with antimalarials.
Yes.
And I think, although we are all the time using antimalarials, and that is part of the recommendations from a lot of societies, we are struggling a little bit with the robustness and clean data with antimalarials. But as good as it can be for the moment for antimalarials, that is a very good and elegant, for me, a reference study, that the co-medication with antimalarials almost reduced the renal flares close to 50%. It's 35 or whatever percent. That is a remarkable finding of the study for me.
Do you think that there were several additional investigation agents that were presented in SLERO? Do you want to highlight any other of them? Do you think there is any promises on the more early phase studies? What do you think, Andrea?
Yes, Raquel. No, I think that there are some of them which are really very interesting. There are, for example, a couple of molecules which are inhibitor of toll-like receptor, intracellular toll-like receptor, and so mostly they have an effect in reducing the type 1 interferon productions. And they are interesting. There are only some projects that are the result, but I think that they are very interesting molecules. Then there are the IL-2, which we already know some results on the trials of IL-2, which is another interesting approach to SLE patients, also different from what we already have, which are the effect on B cells or interferon. Here with the IL-2, we exert an action on another type of cells, which are the T regulatory cells. And so I think that it is also an interesting aspect. Yes, maybe there are also some other, there are antibodies which act on both BLISS and April, which is another interesting approach in the treatment of SLE, which is able to induce an immune suppression higher than that given by belimumab.
Thomas, do you highlight some of these molecular studies?
I completely follow Andrea with this assessment on the torrents, the TLR7/8 inhibitors. That's really excitement in and we have good reason to hope that this might be another good option. But I also think that there is some plus and minus data on the low dose IL-2 use with different approaches. But I in particular also like the approach with nipocalimab, which is an antibody, human monoclonal antibody blocking FcRn, so and able apparently to reduce immunoglobulins. What I find really very interesting, and I think this strategy has already been applied in myasthenia gravis, which is an antibody-driven autoimmune disease, and there is some hope that the same might also apply in lupus, although we are not quite sure whether all of our antibodies are really having pathogenic importance on the one hand, but we will see it. I think the rationale is there to do this also in lupus. The other issue is to which extent maybe subsequent hypoimmune or gamma globulinemia can be tolerated by our patients with lupus having a substantial higher risk of infectious risk.
So we are getting hope that some of these drugs are going to would have the positive effects on phase 3, and then we'll have some of them, as of course you know better than me, they get lost on the way. And I think it was really a good discussion, and it was really giving us hope with these research presentations. There were several patients representative and patients in the meeting, and important insights were also presented from the patient's perspective. And the adherence to medication is still such a common challenge in managing of lupus, and with the majority of patients exhibiting signs of non-adherence. And this could obviously result in lupus flare and possible damage accrue. Andrea, what do you think they are the most important predictors of adherence that we can use in our clinical practice? And what are the main drugs that you think we need to be really aware of adherence and non-adherence in patients?
Yes, it is a very good issue, because it is clear that the drugs, we cannot expect an effect of the drugs that are not taken by our patients. And I see, if I look at the paper published in the literature, it is true that all the drugs can be skipped by our patients without informing us. But in my opinion, the most dangerous one are drugs which are taken in order to maintain the remission in our patients, because they are perceived as drugs which are not necessary, because the patients during the remission phase, they feel good, they feel well, and so they think that it is not necessary to take the drugs. So, for example, one of the most critical drug from this point of view is hydroxychloroquine, where there is a very well demonstration that the dosage of the drug is very low in a consistent proportion of our patients. Among the predictors of as reported by you mentioned, the study promoted by the Lupus Association of Patients, they found that drugs that are perceived as not necessary or in addition, that also toxic are those that are taken less by the patients. And so what we can understand and what we can learn from this study is that we have to inform our patients on the reason for which we administer the drugs to them, and on the effect, the positive and the negative effects. In other words, we have to involve them in all our therapeutic decision in order to motivate them to bring the drugs. I think that it is the most important message that I can have from that study.
Thomas, do you want to add anything?
Yeah, it was, and I think this is a really important area, since we are talking all the time that we are in need for new drugs. And I think it's also pretty much important that the armamentarium that we have already available should be used as good and optimized as much as possible. That's also sometimes what we are seeing in clinical studies, that the placebo is doing so well in lupus in particular. Some of the responses are 35, 40, whatever %. And even in this one IL-2, low-dose IL-2 study, there were 2 centers with 100% placebo responders, which brought the study into some struggle. That's one point. And the most important ones that are seen for antimalarious glucocorticoids. But I wonder all the time how the data what is the frequency for MMF? So for cyclophosphamide, there's no doubt because we are using this IV. For belimumab IV, no doubt. I would, as a good reference, I would love to see the data on subcut belimumab. What is the adherence of patients to that? But we have a lot of possibilities in order to motivate the patients, and I think in particular for the antimalarials and the glucocorticoids, there are good data when the patients are informed and motivated. They are really following our guidance. And the most problematic patients are those where we simply are not able to get their attention to inform them properly in order to take the medication in the most adherent way.
And in your clinical practice, do you have any formal strategy to do this, Thomas? How do you assess adherence? Do you have a multidisciplinary team that to work with the patients that seems less adherent?
Unfortunately, we don't have such a multidisciplinary team. What I do is a kind of proximate or surrogate. I check the pill counts compared to time between prescriptions, that this is plausible. What we also do not have, unfortunately, we are not able to do hydroxychloroquine plasma levels. Some centers are able to do this, not in our place.
Andrea, we discussed this in a previous podcast, but can you just add something on how do you assess adherence in your clinical practice?
Yes, unfortunately, as for Thomas, we do not have a multidisciplinary teams for this purpose. We can, for example, we can measure the blood levels of mycophenolic acid. This is possible, and now we are trying to set up the dosage of hydroxychloroquine, because I really think that it is true that if we are not sure that our patients take the drug correctly, maybe we can add some other drugs which could be useless, and so I think that first of all we have to be sure that our patients take the drugs correctly. Especially, as mentioned before, drugs like hydroxychloroquine that patients perceive as not really necessary sometimes, because they do not feel anything when they take this drug. Glucocorticoid is a little bit different, because when they take glucocorticoids, they feel better if they have some manifestations. With hydroxychloroquine, really, no, it is not. We know that they are good drugs, especially also hydroxychloroquine in the long term, but they do not perceive these things.
One of the things that the study presented highlights is the polypharmacy, and patients, more than half almost half of the patients were taking more than 5 pills a day. Do you think we can think of a strategy to lessen these and highlight what are, try to mix some? Do you have some ideas about this? Andrea, please.
I remember that some years ago, there was Graham Hughes that showed the pills for lupus patients, which is 1 pill with inside hydroxychloroquine, glucocorticoids, MMF, and so on. I really have no solution for that, because we know that our patients must take many different drugs, and I think that even thinking to try to use some pills with more milligram in order to reduce the number, I think that in any case they have to take many different drugs. And so I really have not a solution for this. And if we think at the voclosporin now, in the next future, when we can use voclosporin in our clinical practice, that voclosporin is 6 different pills, 3 pills in the morning and 3 pills in the evening, in addition to MMF, 2 pills and 2 pills, and so there are 5. Also, this is 5 pills in the morning, 5 pills in the evening, and then glucocorticoids, hydroxychloroquine, and so on. You can see that the situation is not going to improve, but is going to worsen.
Yes, with several pills. Do you have a specific pill idea, Thomas, for taking this?
I was just reading this morning an article in the New England Journal of Medicine. It's called Josephine's Story. It was a lady with a severe chronic kidney disease taking 15 pills a day, and she told her doctor, "Tell me, and I don't care which one, tell me which 3 tablets per day I should take." And this was very open. At the end, she went to the casino. But the point is, I think we should learn a little bit from cardiovascular medicine. For example, there are a lot of and even there are publications out that certain compounds can be, let's say, put into 1 pill, like certain antihypertensives together with a diuretic. And we might think about the possibility, in particular for lupus, since we are recommending that hydroxychloroquine, which is in about 65% of patients can be tolerated. Maybe this is a candidate that we can combine this with MMF and azathioprine as a particular lupus-designed therapeutic. That's one possibility. So we have already put two or 3 tablets into 1 per day. And maybe that is one approach how we can tailor therapy in lupus.
But if I can add, I think it is a little bit different, Thomas, from the cardiovascular, because the cardiovascular is a very stable treatment. In lupus, we have to modulate also the MMF, who can decrease the dosage, and so I am a little bit skeptical that the combination with hydroxychloroquine could work.
Yeah, maybe MMF is not a good example, but let's take azathioprine with 150 mg per day. Well, one could combine this with 300 milligram, which is the most frequent, I think, dosage what we are using, and I assume you too. Like with these antihypertensive combined pills, you need to somehow find compromises, but you might have this available in order to meet the requirements of the patients to reduce their tablet load per day.
I think it looks a good idea. And I think that you both and all the results are highlighting that hydroxychloroquine adherence is really important to reduce the risk of early and long-term damage accrual. We saw a recent European survey that has shown that rheumatologists are almost twice as likely to consider patients with renal involvement as having severe disease compared with those without renal involvement. The patients with renal involvement were also more likely to have multiple other manifestations and comorbidities than those without renal involvement. How do you think that the results of this survey compare with your clinical practice? And what are your thoughts on the best options and treatments for patients with renal involvement, not only on the induction part of it, but maintaining? Can you give us some insights, Thomas?
Somehow when I was seeing this presentation at the last European Congress, it confirms our, or at least my impression, that's not black and white, but we see an enrichment of organ manifestations in patients with renal involvement among lupus patients. They have a lot of, or an enrichment also of complications. And I think on the one hand, we see enhanced extra-renal manifestations along the different domains of the organs, but they are also in need for more, let's say, substantial immunosuppression and also other co-medications. I see this also from the pathogenic standpoint that we see an enrichment when we see in the general lupus patients an interferon type 1 interferon signature between 70-75%. In patients with confirmed lupus nephritis, this signature goes up to 85-95%. So this is a kind of enrichment, whether the signature is reliable or not or the unique characteristic of lupus. I need to leave this open, but it already indicates that we have an enrichment of more severe lupus patients, which is also going into extra-renal manifestations.
Andrea, do you want to add something on this?
I agree with Thomas, and I agree with the report that patients with lupus nephritis are among the patients with a more severe disease, because glomerulonephritis is the most common severe manifestations of lupus, because 50% of them they develop glomerulonephritis. And it is true that usually they are the most active patients, and so there is the possibility that they have many other manifestations apart from nephritis. Then it is also true that patients with nephritis are those treated with the most with the most drugs, with the most intensive immune suppression, either with the glucocorticoids and or with other immune suppressant. And so these, of course, this can control their disease activity, but it is also, they also are responsible for the side effects and for the damage accumulation. And so, in other words, when a patient with lupus develops lupus nephritis, his or her prognosis worsens because for a number of reasons. Yes, for the maintenance therapy, what I think is that also in these patients, our main objective, our main targets is to try to reduce as much as possible the glucocorticoids and maybe to continue with an immune suppressant. And we know from the new randomized control trial that it is easier when we add to the standard of therapy one additional drug, which can be a biologics such as belimumab or blinatumomab, anifrolumab, or also a synthetic drug such as voclosporin. And so I think that in the future, what I see as a new paradigm in the treatment is the combination treatment. The combination treatment since the beginning of the disease, not later on, not with a step-up treatment, but a step-down treatment where we can add a combination treatment since the beginning, and then we stop the drugs, of course, one per time. First of all, the glucocorticoids.
So I think that you are both agreeing with this, that renal involvement in lupus is not a different disease. It's just the edge of the spectrum of severity. So we need to think about it as a spectrum of lupus and not a different kind of lupus. So it just wakes up for the need to treat it more. So Andrea and Thomas, thank you so much for joining me today and sharing your insights. To our listeners, we hope these discussions have helped you gain more of an understanding of lupus. Please download the Lupus Academy's 13 European Lupus Meeting highlights report from our website. A link can be found in the show notes. Thank you so much for listening. We hope you enjoyed this podcast. Please leave us a review, which will really help us in reaching as many of your colleagues as possible around the world. Join us again next month for more discussion key issues in the management of lupus.